This is the MyHeart.net podcast. This show is produced by Dr. Philip Johnson in conjunction with VitalEngine.com. Please welcome your host, Dr. Alain Bouchard of Cardiology Specialists of Birmingham, Alabama, at St. Vincent's Medical Center, part of Ascension.
So welcome to our podcast on fitness and fatness and how excess fat can affect your heart. And with me today, I have the famous Chip Lavie, who's director of the Department of Cardiovascular Disease at John Ochsner Heart and Vascular Institute at the Clinical School of the University of Queensland, the School of Medicine in New Orleans. And, we did a wonderful podcast with Chip on cardiac rehab. And when we talk about obesity, I was thinking about Chip not only because of his wonderful Southern accent, but because, from New Orleans, but because he's also a world authority, in the field of obesity and cardiovascular disease. So Chip, thank you very much for taking the time being with us today.
Thanks for having me again, Alan.
So very good. So we'll talk today about the fatness and the fitness and how excess fat can affect your heart. Mostly we're going to talk a little bit about coronary artery disease. We'll talk about heart failure. We'll talk about arrhythmia that includes the AFib and also sudden cardiac death. A lot of people don't realize that. We'll talk briefly about how the treatment for obesity can impact on the cardiovascular outcome. And then we'll talk about the patients that have coronary disease that are obese. How does it affect, the treatment of their heart for these patients that have to undergo bypass surgery or have to be treated for heart failure? So, Chip, let's get started. How excess fat can cause coronary heart disease. How does that happen, and what can we do about it?
Yeah, so the adiposity or fat has a number of bad effects on the cardiovascular risk factors, and particularly the visceral fat. So the difference between the visceral fat, which is the fat around the organs, and the cutaneous fat, the fat under the skin. Fat under the skin might affect the way somebody looks, and maybe it affects that wearing the bathing suit out on the beach, but it really doesn't lead to cardiovascular disease. But the fat around the organs are the visceral fat, and that's often a lot of people think of that as the central obesity, the fat around the abdomen. That has a number of bad effects on the risk factors. It worsens insulin sensitivity, so it raises glucoses and leads to metabolic syndrome and diabetes. It adversely affects our plasma lipids by particularly raising the triglycerides, which is one of the fats in the blood, and lowering the cardioprotective HDL cholesterol, which is the good cholesterol. It leads to raising blood pressure. It worsens inflammation. So the fat cells produce some chemicals that then stimulate the liver to produce some inflammatory proteins. One of the ones that we think about most clinically is something called C-reactive protein, but it causes inflammation, and that's bad on the body. And all of these things, so that it raises the blood pressure, so it then leads to cardiac enlargement or left ventricular hypertrophy. And so all of these things lead to the development of the risk factors that then lead to atherosclerosis. The leading risk factors for atherosclerosis or hardening of the arteries are sugar, diabetes, lipid abnormalities, blood pressure abnormalities, as well as smoking, of course. But interestingly, the smokers don't have as much obesity. The smoking usually keeps the weight down, but smoking is probably worse than almost anything for leading to hardening of the arteries. But the obesity of the fat has all of these other effects that dramatically increases the risk of developing atherosclerosis or hardening of the arteries.
Well, I guess here's one of our maybe classic example. And a lot of times these patients fall under the radar. I mean, they're like the middle-aged men. We'll take the best example, a 49-year-old man. He measures about 5'8". His weight is just a little over, he's about 185. His BMI is 28. But what we miss a lot of times, particularly when these patients, they come in with angina, they're on the cath lab table, we miss that waist circumference. And what you're talking about, this visceral obesity, is waist circumference, was measuring about 38. That's 38 inches. I mean, that's a problem. And even though it didn't seem quite that big, I mean, a lot of times it goes undetected, and we don't.
Yeah, and you say 38 inches, it could easily be 41 or 42 inches.
Yeah.
Despite the fact that they only have a BMI of 28, and so that's a very bad risk factor, is the abdominal obesity, and really the visceral fat is the bad thing, and the visceral fat is particularly an issue with when you have high triglycerides. If you combine the high waist and high triglycerides, you almost always have a lot of visceral adipose tissue. Now, to really measure visceral adipose tissue, you need certain kinds of scans, and those are not typically done clinically. They can be done in research studies like CT scans and MRIs to measure the fat around the viscera, and particularly ectopic fats. Ectopic fats are the fats that occur in lean tissues that should not have a lot of fat, like the liver, like the pancreas, like the kidneys, like the heart, like the muscle, that shouldn't have a lot of fat. When this is the ectopic fat, which is part of the visceral adiposity, is the bad player and leads to all of the bad things that occur with obesity. So just sometimes having big hips, and the gluteal fat is often subcutaneous, and again, that may affect you the bathing suit look, but it's not what's causing you to get hardening of the arteries. And in fact, sometimes the high amounts of subcutaneous fat are generally even protective against having heart disease, because they serve as a reservoir for the bad fat. And so instead of putting the bad fat in the organs and in the visceral adipose tissue, if it's in just under the skin, that doesn't end up hurting you very much. Certainly, the thing that we use clinically is the BMI, and it's called body mass index, which is just a height and weight measurement. And the height and weight, typically 25 is above 25 is overweight, and above 30 is obese. The problem with the BMI is that it doesn't separate fat and muscle. So somebody could be a middle linebacker in the NFL and they have a BMI of 32, 33, and they would be considered obese, but they solid muscle. They don't have any body fat. The fact is, though, in our adult society, there are not that many people who are solid muscle. Generally, when you have a BMI that's 33, most people have a lot of fat. Now some have more subcutaneous fat and some have more visceral fat. Generally, there's a correlation. As fat goes up, both subcutaneous and visceral goes up. But sometimes some people have more of the visceral than the subcutaneous, and vice versa. And that's why not everyone who's overweight or obese develops heart disease.
Yeah, exactly right. A lot of our patients sometimes will have an abdominal ultrasound for one reason or another, and they'll have this report of this non-alcoholic, liver steatosis, that fatty liver. Or sometimes they'll have a CT for another reason, and there'll be reported some incidence of epicardial fat. And this is that ectopic fat that you're talking about, that visceral fat that really...
It's associated with a lot of bad things. It's associated with more inflammation, more cardiometabolic disease, worse effects on the endothelium, which is the cells that line the blood vessels. It's good to have healthy endothelial. And then some of the adipokines that get secreted from the fat cells, they really occur badly with the visceral fat as opposed to the subcutaneous fat. And so really the way that a lot of times we can tell this, is that you can do scans, for the, to look for the visceral adipose tissue. But generally a person whose weight is high, but they have normal blood pressure, normal glucose, good lipids, they don't have high amounts of inflammation, generally that's not the person. And even take it one more step, if they happen to exercise and be fit and still have excess weight. But if everything else is perfect, many of those people don't develop the atherosclerosis. What the reason that that atherosclerosis forms is not just because you have fat. It's because all the bad things that the fat are doing to the glucose, to the lipids, to the blood pressure, to the inflammation. And it's all of these other components of that the fat is causing, or what's leading to the atherosclerosis.
Well, I think we got a good understanding that excess fat can lead to atherosclerosis. How about heart failure, Chip? I mean, how does excess weight can bring about heart failure?
Yeah, so the heart failure is a little bit harder to understand, because we heart failure is a big term. It means that the heart's not pumping good enough to get the blood to all the organs. But we really have two different forms of heart failure clinically. One is when you have a very damaged heart, a weakened heart muscle. And that can be caused by badly blocked arteries and having heart damage from heart attacks, and heart attacks that killed off a portion of the heart. But it also can occur from hypertension, or just getting a virus that attacks the heart. Maybe even sometimes it's happening with the COVID vaccines, or having COVID that can attack the heart. Well, that's causing heart failure with reduced squeeze. So instead of the heart contracting normally, it's contracting at 50% of normal. And that's called heart failure with reduced ejection fraction. Obesity is only a slight risk factor for that. And same way, low physical activity is a risk factor for that, but it's only a slight risk factor for that. But on the other hand, over half of our heart failure today is what's called heart failure with preserved ejection fraction. If you look at the heart squeezing, it appears to be squeezing normally. What the problem is, it's not relaxing normally. And fitness and obesity are major risk factors. Physical activity being low, obesity being high is probably one of the leading causes of this form of heart failure. And so the weight, probably because of multifactorial, raising blood pressure, having effects on increasing the blood volume, leading to left ventricular hypertrophy, the fat around the heart tissue. There are many different reasons why obesity is one of the leading things that causes the heart failure with preserved ejection fraction. In the same way, one of the rhythm disturbances that probably is an epidemic. Obesity is an epidemic. Diabetes is an epidemic, probably because of obesity. But the other thing that's an epidemic is atrial fibrillation. Atrial fibrillation is so common now in our society. And I live in New Orleans, and one big problem with atrial fibrillation is the alcohol is a big cause of atrial fibrillation. But a very, very big cause of atrial fibrillation is obesity. Obesity increases the risk of atrial fibrillation dramatically. With each increase in BMI, there's a substantial increase in the prevalence of atrial fibrillation. So you start combining alcohol and hypertension and obesity, it's not a surprise why we're getting so much epidemics of diabetes, we're getting epidemics of hypertension, we're getting epidemics of atrial fibrillation and heart failure with preserved ejection fraction.
Pretty amazing. I mean, they talk about almost 20% of the AFib that we see probably just come, straight from obesity. Well, now that we're talking about arrhythmias and the AFib, do we know what is the mechanism? Why does obesity, cause this irregular heartbeat of AFib? And also, how can it cause sudden death? I mean,
well, so the mechanism between atrial fibrillation and sudden death is probably not exactly the same. They probably have some overlap. I mean, many people don't necessarily die from atrial fibrillation. They get dysfunction, they get short of breath, they feel palpitations, they get strokes from atrial fibrillation. Probably the most worrisome thing that we deal with atrial fibrillation is a tremendous increase in the risk of stroke. And the atrial fibrillation probably partly comes from the fat around the heart. It comes from the increased blood volume that's dilating the left atrium and affecting the left atrium, which is the chamber in the heart where atrial fibrillation arises from. It raises blood pressure. That's a big risk factor for atrial fibrillation. It dilates the heart chambers and causes left ventricular hypertrophy, which then leads to pressure on the atria, all of which can increase atrial fibrillation. The reasons for sudden cardiac death, which is also substantial. One of my mentors is a guy named Franz Messerli from Sweden. And you probably met Franz before, I'd imagine, but Franz Messerli was one of my mentors when I was a medical student and then a resident here at Ascension. He wrote one of the early papers about obesity being a significant cause of sudden cardiac death. And so the reasons are multifactorial again. Left ventricular hypertrophy is certainly a big factor, probably dilating the chambers and sometimes weakening the heart muscle is a risk factor. Adverse effects on the autonomic nervous system, so decreasing vagal tone, increasing sympathetic tone, which is an increased risk of arrhythmias. We published papers 35 years ago showing that the obese have way more ventricular arrhythmias. Then you deal with sleep apnea, and there's many things that many reasons, but venous thromboembolic disease sometimes presents with sudden cardiac death. So there are many reasons why it's not even all heart, why people can have sudden cardiac death due to obesity, and particularly when you start seeing severe and morbid obesity. One thing right now in our society, which we use the BMI, 75% or 3 out of 4 adults in the United States are either overweight or obese. 42% are obese by the BMI, having a BMI over 30. But what I think is really scary, Alan, is that right now in our society, 9% of adults, that's 1 in 11 adults, have a BMI over 40, which we used to call that morbid obesity. That's not used as much anymore because it sounds too mean to say morbid, but it's now called class 3 or severe obesity. And that's particularly associated with heart failure and risk of sudden cardiac death. So heart failure, one of the reasons why people die from heart failure is from sudden cardiac death. And so heart failure itself is a risk factor for sudden cardiac death. Obesity causes more artery disease, as we discussed earlier. So it blocks up the arteries from atherosclerosis. Heart attack, closing off a main heart artery is a big cause of sudden cardiac death. Fortunately, many of our patients get to the emergency room and we get to open their artery and save parts of their heart, and they can end up having a good prognosis. But a great number do not make it to the emergency room, and a lot of times one of the things that I used to hear, and I don't know if this is still true today, but almost half of heart disease presents with sudden cardiac death. So meaning a guy in middle age dropping dead, that the sudden cardiac death was their first, last, and only cardiac symptom. Now, what we never know is, did they have some symptoms before that nobody knew about? But maybe it was their first symptom, keeling over.
Very dramatic. And particularly, we predict that by 2030, one in every 2 U.S. adults will be obese. 1 of every 4th will have severe obesity, or as you said, a BMI greater than 40. So you can't retire, Chip.
Yeah, and the thing is, it's Alan. What's really scary, I think, is that when you and I were kids, we didn't see any obesity in the children. Kids were out playing all day long, and they were all summers they were playing. The mothers had to call them in to get people into the house at night. They'd have to threaten their kids to get them in the house. Now the kids are on the laptop, they're watching TV, they're watching videos, they're on their smartphones, and getting very little physical activity. And a lot of people blame obesity on the fast foods. They blame it on Coca-Cola and Pepsi-Cola and Taco Bell and Burger King and McDonald's. And that's playing a role too. But I really believe the fundamental cause of obesity has been the marked decline in physical activity that has occurred over the last 5 decades. And not only does that lack of physical activity lead to weight gain, but it also reduces cardiorespiratory fitness. And fitness is one of the biggest predictors of prognosis. So when you combine the two, it's a bad combination. And then, so, if you think about the adults now, many of the adults now were not obese when they were kids. And we're seeing now that the children and adolescents and college students, there's a high amount of overweightness and obesity already. So what's going to happen when they get to be 50 years old if they're already starting off with a lot of adiposity?
That's a very good point. I mean, we see, a lot of patients, but the women, particularly when they get into their menopause, they start getting all this weight. They didn't used to have this problem. So, they're looking at the BMI and say, my God, 10, 20 years ago, I was like a normal person. I exercised and did everything. So if you kind of backtrack to all this young population coming in, with already obesity, it's not going to be a pretty sight, unless something is done. Well, let's talk about things that we can do. So let's say, for example, we talk about the repercussion of the excess fat on the cardiovascular system. Now, what if we treat obesity? How do we affect, the cardiovascular outcome?
Yeah, so first of all, we know that obesity is a big risk factor for developing all the cardiovascular risk factors. And we know it's a risk factor to developing heart disease, coronary disease, heart failure, atrial fibrillation, et cetera. We know that people who don't become obese don't get as much heart disease. So that's pretty well known. What isn't as well, and also obesity is the driver of diabetes. And so diabetes is a big risk factor for every type of heart disease. It's a big risk factor for getting atherosclerosis and getting heart failure. Probably is a little bit of a risk factor for getting atrial fibrillation. So we know that all of this happens. What we don't have as much evidence is intervention in obesity. It would make sense that you can stop all of these things if you did a vigorous weight loss program, if you went to Jenny Craig, or if you got on the medicines now that they have get ones that are looking better and better, or if you do bariatric surgery. About the only thing that we know right now is that people who don't gain the weight don't develop the heart disease. And we know that the people who have diabetes, who get treated with bariatric surgery, they actually improve their prognosis and decrease their cardiac events. And there's a little bit of data with a couple of the diabetic medicines, the GLP-1 agonists, liraglutide and semaglutide, that at least in diabetes look like they're reducing cardiac events in the diabetic patients. In all likelihood, that same logic would reduce heart disease across the board. That has not been clearly shown in randomized trials. We project that that's the case. And there's trials right now with some of the agents. There's trials with bariatric surgery. There is some indirect evidence that, for example, for heart failure, there have been papers that showed that if patients had severe obesity and they had heart failure events, been hospitalized for heart failure, and then they get bariatric surgery, the ones who got bariatric surgery have a lot fewer hospitalizations for subsequent heart failure than the ones who didn't get bariatric surgery. The problem is that's not randomized data. It's just looking at big, large cohorts of like either elderly or Medicare cohorts. But I think it makes sense that that there is some indirect evidence that you're decreasing heart disease. But what we really need is the randomized studies, and those are being done right now with some of the higher doses of the diabetes medicines that are showing pretty substantial. Some of them are showing 15, 18% reductions in body weight. and that's getting close to the 25%, 30% reductions that occur with bariatric surgery, which is, a surgical procedure. So we now are getting some medications that can get close to that amount of weight reduction. They look like they're very safe in diabetes, and I think they're going to be proven to be safe. And so what we need to know, how do these agents then do to lower clinical cardiovascular events? I think we're going to probably have some data starting to come in the next several years that will better assess this. It's going to probably be a decade before we get all the data in on that. But I'm pretty confident that that's going to show benefits. It's a shame that it's gotten to that point, though, because if people would start with physical activity earlier and either prevent the weight gain at the outset, or even if you don't prevent the weight gain. If you take the guy who's 50 years old, who's gone from being 160 pounds when they were in high school to now they're 230 pounds, and they've gained 70 pounds over the last 35 years. But if you got him to even if he didn't lose weight, I think he would be better off if he actually lost weight. But even if he didn't lose weight, but you got him to exercise and get fit, where he didn't gain more weight and didn't go from his 220 pounds to 300 pounds over the next 10 or 15 years. So if you prevent the going from a BMI in the low 30s to a BMI of in the low 40s, that's likely going to happen over the next many years. But then also, a person who's fit can have a quite good prognosis even at a higher weight. So the perfect world would be for all of our patients to remain lean and fit their whole life. And we know that that's not happening. What's happening is they're gaining weight and they're losing physical activity and fitness. And so what I'd like to say in my writings and my lectures and my even books is that if you're going to do one of the two, it would be better to gain some weight and maintain fitness than vice versa, because I think that fitness is even more important than the weight for long-term prognosis.
Very good point. And you've always been a proponent of fitness, even over fatness. And if you can keep your fitness, you're likely to really kind of prevent a lot of these heart attack, occurrence of diabetes or hypertension as a complication of your weight.
So I'm 63 now, Alan. And so even when I was doing more races, I still will do an occasional one. But when I was in my 30s and 40s and I was doing lots of races, I was running some pretty good times, but I'd be in a race and I'd turn to my side and I'd see a guy that was 40, 50 pounds heavier than me passing me up. And I'm going, now, of course, that person has a lot of talent and he probably would have been even running faster if his weight was 40 pounds lighter. But you can be heavy and be fit, and so that if you do physical activity or exercise, there certainly is a genetic component of fitness as well. But if you do physical activity and exercise, of course, that will keep you from gaining weight in the long run or gaining more weight. But if you can get yourself fit, even at higher weights, now you're not going to have too many people that have BMIs of 45 that are fit, but you can be BMIs in the upper 20s and low 30s and be pretty fit. And you could be fitter than somebody who has a BMI of 22, 23.
Well, in the Ironman, we call them the Clydesdale, and they're flying by you. I think it's really wonderful. Well, I think that's a very good point. Now, let's say, for example, you do have coronary artery disease and or heart failure, and you're obese. What is, how does the treatment of cardiovascular disease affect that patient if you have obesity in addition of everything else? How does it affect, for example, if I need a bypass surgery and my BMI is like 38,
So one, there's a lot of effects that obesity have, just for example, if you need a bypass surgery and your weight's very high, you have more chances of getting wound infections. You have more chances of having a harder time getting off the ventilator after surgery. Now, once you do get off the ventilator and you get into recovery, the data actually looks like that, and this is what's I think confusing to people. That and you and I have talked about this before. that if 30 years ago I was sitting with two people that just had a heart attack or just got a stent or just had a bypass surgery, and they came back to the office, and one of them had a BMI of 22 and one of them had a BMI of 32, I would have thought that the guy with the 22 BMI would have a much better prognosis. And the data looks like it's just the opposite of that. Now, again, there's a lot of individual variation, but the thing is that the reason for that is probably that the person who has the BMI of 32 that just had a cardiac event, they probably wouldn't have gotten heart disease in the first place had they not gained the weight. Whereas the person who has a BMI of 22 who develops the same heart disease, on paper, they look healthier. They have a better glucose, they have less inflammation, they have lower blood pressure, they have lower triglycerides, they have higher HDL, lower blood pressure, but they do worse. And the reason for that is probably, one that maybe good was because they were a heavy smoker, but the other reason is that they got the disease for a different reason. They didn't get the disease because they gained 70 pounds. They got the disease because of genetic predisposition. And so I like to say that, again, everybody would be better if they were fit, but for the majority of the patients that you and I see in the office now are not BMIs of 22. They're BMIs in the upper 20s, in the low 30s, or even in the 40s now. But if we can get those people who have a little bit of weight in high 20s, low to mid 30s, if we could get them fit, if we can get them physically active and fit, their prognosis can be quite good. And it could be better than the thin person who's unfit. If you're fit, it doesn't really matter what you weigh as far as prognosis. You can have a quite good prognosis if you're fit. But the unfit people, we're actually seeing that in the cardiovascular disease patients, if you're unfit, you're really bad off if your weight is very low. And that's probably because you don't have muscle, you don't have reserve to fight illnesses. And if you're physically weak with low muscle mass, you really can have a bad prognosis.
Very good point. What about if you have heart failure and you're overweight or obese? I mean, it seems like we have, and particularly with what you mentioned, the HFpEF, we have some wonderful medication now, and it seems like, you have obviously the spironolactone, but also all these SGLT2 inhibitors. I mean, it seems like the Jardians and all these drugs should be working very well in our favor.
So we have great heart failure medications now. We've had beta blockers for years. Of course, you have to use the diuretics, but we have now the Entresto, which has been better than the ACE inhibitors and angiotensin receptor blockers. Entresto is very good for heart failure, and like you mentioned, the SGLT2 inhibitors, which are diabetes medicine, but are actually having great effects on heart failure, even if you don't have diabetes. You're getting just as much benefit from these diabetic medicines in increasing your survival or decreasing your hospitalizations for heart failure. And so we do have a lot of things. Now, weight loss in heart failure has been shown to improve symptoms, functional capacity. It's improved the heart contraction ability. There's no data right now showing that it improves survival. I think that the data is all more on softer endpoints, but I do think that that the studies that are going to come out that's showing that weight loss in these patients, and certainly we have some evidence. We don't have a big heart failure trial with bariatric surgery. We have retrospective data that I mentioned earlier, but no one's done a trial of taking obese patients and randomizing them with heart failure to bariatric surgery versus no bariatric surgery. But I think that the data we have is certainly looking like that weight loss and heart failure is improving the symptoms, the exercise capacity, the fitness is having beneficial effects on the heart structure and function. And it's certainly reducing hospitalizations, which are very important too. I think they would actually improve survival as well, but we don't have a study that absolutely shows that right now.
Well, let's talk about, arrhythmia and AFib. I mean, it's such a big topic. And as you mentioned, there's so many patients with AFib now, and there's such a connection between obesity and AFib, and also the effect of treatment.
Yeah. So for example, somebody who's very, very obese, it's harder to shock their heart out of atrial fibrillation because that you need more voltage, and a lot of times you can't get good penetration of the electricity to shock the heart back to normal. And we certainly know that there have been trials in, for example, atrial fibrillation, that if you can reduce your weight, particularly if you can reduce it by over 5%, and even better if you can reduce it by 10%, but even if you get 5% reduction in weight, and you can improve your fitness, that you can actually reduce the occurrences of atrial fibrillation. No one's actually shown that you take that patient that you actually improve their survival, but it has been shown in randomized trials that in reductions in weight and improvements in fitness, and particularly if you do both at the same time, you can really reduce your recurrence of atrial fibrillation, which is a pretty nice endpoint too, because one, people don't feel good with atrial fibrillation. And we know that atrial fibrillation is a big risk factor for stroke.
So it's particularly important also when they're planning some ablation, of the atrial fibrillation. I mean, the results are so much better when the patient loses the weight, as you mentioned, less recurrence and less chance also to develop persistent AFib. Yeah. Then, you're really in trouble. But you lose that atrial kick, you're really going to be short of breath, particularly if you carry that extra weight. I think
there's some evidence that would say ablation procedures also don't work as well, and they have more complications in the very, very heavy. I think ablations probably work fine in the overweight and mildly obese, but in the very, very heavy people, there's some technical challenges, associated with very severe obesity. We also, just for things like, using the anticoagulants that we like to use in for atrial fibrillation, the ones that, things like the Pradaxa, the Eliquis, the Xarelto. We really don't have many studies in the very severe obese. We do have studies showing that those medicines work good in the mildly obese, but we don't have really studies with 45, 50, 60 BMIs that we sometimes seeing now with atrial fibrillation, and so how do you know what dose? And so sometimes some people even recommend that maybe we should use the old medicine, warfarin or Coumadin. At least you can measure their response, and we don't know the response, of say, as well, at least with Eliquis and Xarelto and Pradaxa.
That's a very good point. Plus the problem with sleep apnea and AFib, so if you want to prevent AFib or have a good ablation success, you may even be able to avoid ablation if you kind of work on the weight and the sleep apnea.
And the sleep apnea. If you improve your sleep apnea, you can
avoid ablation.
Substantially, reduce your risk of having atrial fibrillation.
Yeah. Well, Chip, I want to thank you very much. I mean, now we know a little more about, how excess fat can really affect your cardiovascular system. We know also a little more about what to do about it. And it seems to be, there's still a lot of research to be done. You've always been in the forefront of this, and we really appreciate your input. We probably will have to kind of reconvene again at some time in the future to see how these trials, that you're conducting, are happening.
Well, thanks for having me, Alan. It was a pleasure. And, if you ever need me to do another one, I'm happy to do so.
To learn more from our team of cardiologists, please visit us at MyHeart.net. You can also follow us on social media by searching MyHeart.net on Facebook and Twitter. And be sure to subscribe to this podcast so you don't miss our next episode.